The next presenter is Associate Professor Freddy Cetus, who is from the same centre that I'm from. He's the Director of the Centre for Primary Health Care and Equity. He's got 24-year track record. Particularly, he's got particular expertise around smoking, but other risk factors for cancer, and as well as having contributed to the WHO Agency for Research on Cancer monographs on carcinogenicity and cancer in Africa. He's currently chair of the efficacy section of the Clinical Oncology Society of Australia Working Group on Smoking Cessation and Cancer. Over to you, Fred.
Thanks very much, everybody. Thanks, Mark, for the introduction. I'll be talking to you about obesity, the effect of obesity on cancer in the next 10 minutes. It's a vast topic, and I'm trying to squish it into a very short period of time. So just without much ado, what is obesity? We're working on a definition of what we normally call a BMI. It's a body mass index, which is your height divided by your weight squared, or weight divided by height squared, one of the two. And so you take somebody's weight, you take somebody's height, you double the height, you divide the one by the other, and you come up with a BMI. And there are many other measures, but for the rest of this talk, I'm going to be focusing on BMI. There's figurines that you can use. Those are the Stunkard figurines. So you put, what do you think you look like? You point to a figurine, and that correlates with BMI and other measures. There's adiposity, central adiposity. There's also weight to hip measures. The problem is, you've got to find the weight. You've got to find the waist, and you've got to find the hips sometimes to measure these things. And sometimes they're very difficult to do. Whereas weighing somebody and taking somebody's weight is just fine. And then as you go down the list, the complexity becomes more expensive. Okay, so you get CT and MRIs. You can look at various things there, but you've got to pay a lot of money, or the client has to pay a lot of money, or the government has to pay a lot of money to classify people into those sort of things. There's a eureka moment there where you put people underwater and you pull them out and you work out things. And yeah. Anyway, so. This is the graph on the left, this side. It's from WHO, but it's the Australian weight. It's the Australians' median weight, mean weight across time. So on the bottom here, we've got 1975, 2016. So this is in children, and this is in adults. Okay, 25. That's BMI of 25. It's going up, but the nice thing is plateauing, which is really, really, really encouraging. I'm hoping it plateaus and starts coming down for some unknown reasons. The causes of that going up, we kind of think we know about. The causes of it coming down, we're not quite yet sure how we're going to do that. But it's encouraging that things have started plateauing from around 2010, and hopefully they'll keep going down. However, having said that, 63% of the Australian population is overweight or obese. That's a BMI of over 25. And if you look at the classes of obesity, 18, 6, and 3% are at different classes of obesity, which is over 35. So that's a substantial 18, 19, 27% are obese, which is quite a high proportion. Okay. What do we look like compared to the rest of the world? Okay, so 29% are obese in Australia. We've got a neighbourhood of islands which are in the obese category. 40 to 60% are obese. Okay, the lowest levels of obesity are in places like India, Vietnam, and Bangladesh, 2.1%. And I've put there a couple of illustrative other countries, like in UK, 28%, USA, 36%. The USA is a bit ahead of us, and we're on par with the UK. Okay. So there are places when you've got a common disease or common condition somewhere, it's rare somewhere else, and it's important to look at the causes of why things are rare and the causes where things are common to find out what we can do to emulate those lifestyles to make it less rare. I found this really nice definition of obesity. It's bad diet and little exercise. It's where there's, obesity is like a Tesla, it's like a battery, it charges up, and, the more you use it, it goes down, and energy you put in and energy expenditure. And the main international guidelines around the kind of dealing with obesity is to have a balanced diet, reduce that calorific load, and improve physical activity. And if we keep those solutions as simple as that, we might get some traction. It's interesting when I walk down Charles Perkins Center or various places where there's a lot of interesting work being done. But every expert you talk to, you get a slightly different story. And I think that's the problem when you move away from smoking, when you know what the problem is. You've got one vector, a couple of diseases, you've got one environment that's much easier to deal with. And that took about 50 years to get to where we are now. Smoking is chicken feed compared to what we have to do with controlling BMI. But this is, so a big BMI, so a BMI of over 30 doubles one's risk of death, okay? Now, that's quite an important fact from a general practice point of view. People like talking for individual diseases, but collectively, somebody with a high BMI has a doubling of risk of death. It's not all diseases, it's some diseases and not others, and this is a really nice paper from The Lancet. The squigglies that go up are the ones that are bad for you, and the lines on the top line is the cancers. Okay, there's a few cancers that are associated with BMI. There's some that are not. Lung cancer, for example, is not. And then the second row is cancers as well. The third row is cardiovascular and endocrine diseases. Sorry, blood and endocrine, mental behavioral. This one is cardiovascular diseases. So a lot of the cardiovascular diseases are related with BMI. Respiratory diseases, some of them, okay? And then accidents and things like that, a bit of a wishy-washy evidence around that, negative evidence. But the main causes are cardiovascular, some metabolic like diabetes, and some of the cancers. What else doubles one risk of death? Well, smoking, okay. Alcohol, 8 standard drinks a day. I'm just trying to give you a scale of how dangerous BMI is compared to other things, okay? HDL higher than 5.4, that's from the Framingham study, and a CRP level greater than 10. Okay, those are the things that if you measure on a well person, you should be, it's a heads up, okay? From Australian burden of disease rankings, high body mass is the second most important cause of premature death and disability, okay? So that's very important. Smoking comes first, but BMI comes second. As I said before, obesity causes certain cancers, but not others. It causes about 5% of all cancers. This is the list here. Over here, colorectal is the main, because of the numbers, colorectal is the main one, breast is the main one. But there's emerging evidence on the importance of liver cancer in BMI, and you'll hear about that a little later. And this is the fraction of deaths of cancers caused by obesity in different countries. 5% in Australia, very little in Africa, very little in Asia, and a lot in Western European countries. We do have a communication problem. We asked 3,500 people what they think caused their cancer. Stress is the main cause of cancer from the people's point of view. Diet, about 5% said poor diet. But a lot of the things is genetics, things that are just completely not related to anything that the scientists think cause cancer, what the science shows. And this is work from the 1980s, what Richard Peter and Richard Dolph think causes cancer. Tobacco is the main one. The second one was diet, and that's been disaggregated since the 80s into exercise and BMI and that sort of golden triangle. But diet and BMI, the sort of anthropometric or metabolic factors, are very common. This is a graph of what's happened since the 1980s in cancer rates in Australia. And I've marked in yellow in red the ones that have gone up that are associated with BMI. So things like uterine cancer, thyroid cancer is a new one, that's gone up because of diagnostics. But some of it's been associated with, and liver cancer's gone up, kidney cancer's gone up, cervix cancer, of course, has come down because of screening, breast cancer's gone up by 40%. Not all of it is due to BMI, but these are the cancers that have gone up in incidence over the past, since 1987. And just to illustrate that some cancers have gone up, some of them for many reasons, but some of them associated with BMI. We know that certain things work. The purpose of this workshop is to increase your confidence that things that GPs do can work. And part of the thing that interferes with our ability to tell people or encourage people to lose weight is getting that evidence on top of us so that we are comfortable with the evidence and persevere with patients on various things that could work. What can you do? There's the 5 A's. You're going to deal with that in the rest of the course of the afternoon. And that's all I think I've got to say. That you'll get the slides with all the references that are related to the talk. Thank you very much.
Thanks very much, Freddie.